Hello again, and thank you for joining us for this webinar on Infusion Services. My name again is Mary Sue Gardner, and I am a nurse in the Provider Outreach and Education Department. And I'm joined today by Rachel and Jennifer, the other nurses on our Provider Outreach and Education Department, as well as members of our medical review team and other members of our Provider Outreach and Education team, who are going to be helping me with the question and answer portion of today's call. Now, the purpose of the webinar today is to let our providers know about the review findings related to Infusion Services reviews. The TPE reviews focus on those codes that fall under the subsection of hydration, therapeutic, prophylactic, diagnostic injections and infusions, chemotherapy, and other highly complex drugs and biologics. This is our disclaimer. We show this at the start of every one of our events, and this disclaimer basically says that this education was prepared as a tool to assist you, our provider community, but the Medicare rules and regulations often change, and it's your responsibility as a provider to make sure you are following the relevant laws, rules, and regulations as they stand for that day of service. So everything I'm going to tell you today is current as of today, but if the laws, rules, and regulations change tomorrow, it's your responsibility to make sure you're following what the updated changes are tomorrow. We are going to provide responses to any questions that you have based on any facts that are given or, the laws, rules, and regulations as they are today. And finally, CMS prohibits the recording or taking screenshots of this presentation for any profit-making purposes. So like I said at the beginning, we are recording this for you, and this will be put on our website as an encore, put on the YouTube page as an encore for this event, so you can go back and listen to it at any time. This is a list of acronyms and abbreviations, things that I may say or may refer to or may be typed out in our presentation. So if I use an acronym or abbreviation you're not familiar with, you can go ahead and refer back to this page. All right. My overall objective for today's event is for you, our providers, to gain some invaluable insights to empower your practice with the information and help you ensure compliance with infusion services. And I really hope to accomplish this today by reviewing the Medicare coverage rules. We're going to be discussing essential documentation requirements, and we're going to dive into some specifics of recent medical review findings. And following our formal presentation, we'll also pause if we have time at the end for some questions and answers. You can place questions into the chat at any time and send your questions to all panelists. So let's get started and talk about infusion services. So infusion services refers to the process of delivering liquids such as hydration or medication or even nutrition into the bloodstream through intravenous methods or IV catheters. There's generally 3 types of infusions that can be given to a patient that Medicare covers. So these include things like chemotherapy and other highly complex drugs or highly complex biologic agents, therapeutic, prophylactic, and diagnostic injections and infusions, and then IV hydration. All right, so chemotherapy and other highly complex drugs and biologic agents. So the CPT code range of 96413 to 96417. And I apologize for my dogs, but it is what it is when you work at home. So chemotherapy administration codes apply to parenteral administration of non-radionucleic anti-neoplastic drugs and also anti-neoplastic agents provided for treatment of non-cancer diagnoses or to substances such as certain monoclonal antibody agents and other biologic response modifiers. The highly complex infusion of chemo and other drugs or biologic agents requires physicians or other qualified healthcare professionals. It requires their work and their clinical staff monitoring well beyond that of therapeutic drug agents. So those that are in the 96360 to 96379 realm. Because of the incidence of severe adverse patient reactions are typically greater. So for our purposes under the TPE, we're looking specifically at the CPT codes 36413, which is chemo administration, IV techniques up to 1 hour. That's the initial substance. And the 36415, so that's the each additional hour. So as we move on, let's talk a little bit about the chemo administration coverage. So the term chemotherapy includes, again, the highly complex drugs or highly complex biologic agents. Chemo administration codes applies to those, again, in the parenteral administration of the non-radionucleic or anti-neoplastic drugs. So there's anti-neoplastic chemotherapy agents provided for treatment of non-cancer diagnoses, and that can include other substances such as certain monoclonal antibody agents and other biologic response agents. Anti-anemia and antiemetic drugs given to cancer patients by infusion or injection are usually not billable as chemotherapy administration. So the coverage requirements for chemo include the things here on the screen. So these infusions typically require physician or other qualified healthcare professionals monitoring because the incidence of severe adverse reactions are typically higher or greater in the administration of these drugs. Typically, these infusions require advanced practice training and competency for those staff who provide them. And these infusions require special considerations during the preparation, dosage, and disposal. So what does all that mean? That means that the documentation that you provide to us needs to show that there is qualified healthcare professionals that are doing the typical monitoring of these patients that would be required. So those people are always on site with the patient, monitoring their overall care. We're typically not going to ask you to show us the advanced practice training that these staff have. However, there are other review entities or the state that could come in and ask to see those things. So make sure that, you know, the training is all kept on file as well too. We're also going to make sure that things are done and prepared as they should be. Again, a lot of that will come down to the laboratories, special preparation, and those are other things that we're probably not going to ask for, but the state could definitely come in or any other review agency and ask for those things. So as we move on and talk a little bit more about the chemotherapy documentation, documentation for administration must support that CPT code that you're billing. So again, the CPT 96413, which falls under the injection and intravenous infusion of chemo and other highly complex drugs and biologics. So the documentation for that must contain information about the agent being billed with the 96413. So what's the chemotherapeutic agent that is being administered? We need to see in the documentation the primary reason for the encounter, and that it is related to the chemotherapy administration. So that would include things like the diagnosis that you're administering that specific agent for. We need to make sure only one of the initial infusion codes was billed unless you have two separate IV sites that are supporting that. And then the documentation, we also need to see the medication administration record, or MAR, with the infusion start and stop times, or the total infusion time. Other documentation includes the physician or non-physician practitioner's order for the medication infused, evidence of frequent monitoring during the infusion, and evidence of billing, the supervision of the chemotherapy infusion. Now, before we move on to the next slide, I want to talk a little bit about some of these things and what kinds of things as a review entity we pick out of your documentation. So again, somewhere in the documentation, in your evaluation of this patient when they first come in, we need to see the primary reason for the encounter and how that reason relates to the chemotherapeutic agent. So we need a diagnosis. We need to see what agent is administered, and we need to see the plan for administration of this chemotherapeutic drug. How was it ordered? How is it to be administered? Do we have any kind of peak and trough time lab levels that need to be drawn? Do we have any other special considerations that are ordered and being monitored that go along with it? When we look at your medication administration record, we're going to make sure that your drug being billed matches what's on your medication administration record. Again, we're also going to look and see when did it start, when did it stop, or the total infusion time that goes along with that. We picked a lot of the information out of your medication administration records. Are there any other infusions, flushes, drugs or biologicals that are also being administered as well as the chemo? Are those being reported correctly? Can we see in the documentation that the correct number of units that was billed is supported on your medication administration record? Your physician or non-physician practitioner orders for the medication. Does that include the right patient, the right dose, the right rate, the right flushes, everything that goes with it? Has the physician given you basically the plan and okayed the overall plan in his or her orders? So as you can see, these specific pieces of information give us a lot of insight to what is going on with the billing, and we need to make sure that what you put on the bill matches what is in your documentation. So if we continue to the next slide and continue to talk about some of the documentation for the 96413. The other things we would expect to find include the fact that the infusion was given via IV. That should also include information on the site or the port, et cetera, of the patient. Your medication administration record should be evident that the infusion billed was under the 96413, that it was the initial medication for the visit, and that the infusion lasted for at least 16 minutes. And that's all part of what is in your CPT code manual. So that's one of the first places when you're trying to support in your documentation what's on your bill is what does the CPT code manual say about that specific CPT code? If it is, if it gives time that you have to meet in your CPT code manual, do you also have that time in your documentation? If there are other codes that can and cannot be administered with the drug, do you have evidence of that in your documentation? So I do see that someone put in a question. It just happened to pop by my eye, and I've been saying, proof of monitoring, proof of this, proof of that. So your documentation for like the administration and the monitoring by the nursing staff should include information about every time that nurse is checking the IV administration site. When the nurse checks, do we have documentation that the nurse made those frequent checks of the patient, that we're monitoring the vitals? Do we have the documentation of the vitals? If we're monitoring INOs, we have that information as well. Are we checking for, increased temperature? Are we checking the infusion site? Every time those checks are made, it should be documented. If it's not documented, it's not done. And that goes back to documentation 101. So how do you support your doing what you're doing is you make sure it's captured in your documentation, whether you're keeping those things as flow sheets, whether they're part of your routine checks, or whether you have to make separate entries into your electronic medical records where you can put in some objective and measurable information about your patient, that you type in separately if there's something adverse that comes up outside the norm. All right. So as we move on, let's talk about some of the documentation for the 96415. So continuing along with that, we would expect all of that information that I previously mentioned in the documentation, as well as the medication administration record and the documentation to support the additional hours of the medication infused. So same medication, but the infusion must be greater than 91 minutes or longer to bill it. So this slide kind of breaks down for you what you would report, what you would need to report those additional units. So 1 unit would be 91 to 150 minutes, 2 units, 151 to 210, etc. And I see a question did pop up, and I'm not seeing all the questions, but occasionally I see one pop up in the corner of my eye. And this is available in the slide deck for download. And I am going to have Rachel go ahead and place a link to the slide deck back in the chat. So if you need a copy of this slide deck, you can definitely go out and get it either now or at a later date and time. All right. So moving on, know what codes can be billed with the 96413 and the 96415. So if you're the person that bills for these services in your facility, it's important to know what you can and cannot bill together. In your slide deck, the word hospital procedure to procedure codes is linked. So right here, this is a link that's going to take you out to the CMS site. And so you can look at those hospital procedure to procedure codes. I am going to actually link out and give kind of a real quick tutorial of how to figure out what codes can and cannot be billed together. So again, I provided you that link, but if you were to just make a search on the CMS site for the NCCI procedure to procedure codes or National Correct Coding Initiative procedure to procedure codes, you can go and do that. So you can see the 2024 files for first quarter are already posted. I'm going to go ahead and I'm going to select this last link because I am looking for codes that fall in the 9,000 range. So you can see the end here. These are the 2,000 range to the 3,600 and also include some G codes, etc. This is the 6,000 to the U codes. So I'm going to select that file. And as I go down, it's going to ask me to accept it. Accept the disclaimer. I am going to save it. And it is going to save as a PDF or as a zip file. Got to give me just a second. Let me open the zip file here. And it's opening on my other screen. So I'll pull that over for you to see. Whoops, maybe. There we go. And I'm going to open the Excel file that goes along with it. So you have a text file or an Excel file. I find it's easier to use the Excel file. Minimize that. As the Excel file opens, I will pull that into view for you. And, oops, let's go ahead and pull that on over. Okay. So again, we're looking at those codes that are in the well, we're looking specifically for this one, for the 96413. I find it easier just to do a Control F, which is a find, and type in the code, 96413. And then I'm going to find every time that code is in this list. Whoops. And I want to look for it in the primary field, so in the first code field. So we get down here where the 96413 starts to appear in the first code field range. So again, the purpose of the NCCI procedure to procedure edit is really to prevent payment of services that should not be reported together. So each edit has a column 1 and a column 2, code. Okay, so the CPT or HCPCS codes, they're either column 1 or column 2. If a provider reports the 2 codes of an edit pair for the same beneficiary on the same date of service, the column 1 code is the one that's eligible for payment, but the column 2 code may be denied unless it's clinically appropriate and there's an NCCI procedure to procedure associated modifier. So again, we're going to look at F is the modifier field, and if we scroll back up to the top, and I'm not going to do this because I just kind of want to stay in this area, but the very top of this gives you some information on the modifiers. So if there's a 0 in this column, that means a modifier is not allowed. If there is a 1 in this column, that means it is allowed. A 9 means it's not applicable. So for our purposes, I want to look specifically at 35878. I pulled this out earlier. 358, and I might be a little off. All right. Down here. So let's look at this one, because this is pretty typical. So this one in column 1 is the 96413, and column 2 is the 96360, which is hydration infusion. There is a modifier in this column of a 1. So in column F, modifier of 1, which means it is allowed to be billed together. And then you go to column G, and column G gives you instructions that you need to follow the CPT code manual, or the manual for coding instructions on how this can be done. So if it's an add-on code, or if there's time-specific requirements, etc. So that's how you find out if these codes can be billed together. And if there's additional instructions, then again, your biller and coder should go out to the CPT manual and find those additional instructions to make sure that what you're reporting on your bill is correct. As a provider of these services, it's really your responsibility to make sure you're checking this procedure to procedure list and reporting these codes correctly. So I am going to go back to our presentation and bring that back up. So again, how do you know it can be billed together? You're checking your code manuals, and you are checking the procedure to procedure code list. All right. So as we move on, let's talk about therapeutic, prophylactic, diagnostic infusion. So that falls in the 96365 to 96371 range. A therapeutic or prophylactic or diagnostic IV infusion or injection, anything other than hydration, is for the administration of a substance or drug. So when fluids are used to administer drugs, the administration of the fluid is considered incidental hydration, and it's not separately reportable. For the purpose of this event, we're only going to be referencing the codes in the 96365 to 371 range. So again, administration of substances of drugs other than hydration can include things like antibiotics, antivirals, antiemetics, etc., but excludes chemotherapy. So coverage, these services typically require direct supervision for any of the following purposes of patient assessment, provision of consent, safety oversight, intra-service supervision of staff. Typically, such infusions require special considerations, again, for preparation, for dose or disposal. They require sometimes practice, training, and competency for staff who administer them, and they require periodic patient assessments, vital sign monitoring during the infusion. So kind of going back and talking about, comparing to how we talked about this versus the chemotherapy. So there does need to be some special consideration depending on the drug. Does the staff that's administering this have to be competent in the preparation of the drug? Absolutely. In the administration of the drug? Absolutely. Are there special considerations for specific drugs? Some do not require as frequent monitoring. Some require that we are doing specific like peak and trough times for that drug, so we're drawing those labs. We're drawing those labs, at specific times. Do certain things need to be monitored at certain times during the administration, et cetera? That's how we're going to look for the competency and the training. Again, we as Medicare are probably not going to ask for your staff training information, but it is stuff that your facility needs to keep on file because the state or other agencies can walk in at any time and ask for those types of things. So as we move on and talk a little bit more about the documentation requirements, when it comes to the documentation requirements for the therapeutic and the prophylactic and diagnostic infusion, some of the things we're looking for, again, are what's the primary reason for the encounter related to this specific infusion. So we also look to make sure your infusion code is matching your documentation. So what's on your bill is a direct match for your documentation. And again, only one infusion code can be billed unless you do have two separate IV sites that are reported. Just like with the chemo, we're going to look at your MAR, your medication administration record. We're going to look for those infusion start and stop times or that total infusion time. We're going to look to make sure, again, that the drug matches and that it was dosed over the appropriate time. Physician's orders for the medications infused go back to everything I said at the beginning about the chemo. Did the physician order give you all information about how this drug should be administered? Do we have run times? Do we have rates? Do we have any other fluids that are supposed to be administered with the drugs and their rates, et cetera? And then again, is there evidence of monitoring? And when we consider monitoring, we're looking basically at the nursing staff, any other ancillary staff. We're looking at lab values, lab draws that were done, anything that provides evidence that while this drug is being administered, we're following the things that are required for this therapeutic or prophylactic or diagnostic infusion. And we're doing our vital signs. We're checking sites, administration sites, whether that's a port, whether that's an IV, you know, whatever the case may be, however it's being infused. We're looking for any kind of injection reactions or infusion reactions, et cetera. And that we're looking to make sure that your clinical staff is documenting and following these things in accordance with the medication that's being administered. All right. Really, as we talk about all this stuff, it's important for you to remember that your documentation really should be able to paint the picture of your patient's visit or your patient's stay at your facility. So we want to make sure, and we want to look through your documentation and make sure it's evident that we know what is being administered, what infusion is being given. What is it being given for? How is it being administered? We're looking to make sure we can see when did it start, when did it stop, or what's the total infusion time. We again, your picture should show what does staff need to watch? Are there specific things for this specific infusion that we should be watching for? Are there typical infusion reactions that may be more likely than others? Is there documentation to support that specific monitoring was done for that specific patient for that specific medicine? Again, blood levels, et cetera. So when you think about it, you want your documentation to be an overall picture of your patient's stay with you at that time. And if someone were to look down at your picture, which is your actual documentation, is everything evident? Does it match what you build? And can we see, here's what the patient arrived for, here's what they're supposed to be getting, here's how it's supposed to be administered, here's how we watched the patient, here's how we monitored, here's the lab works we did. this was the patient's, how they responded to the infusion, and this is when the infusion stopped, and this is when the patient left. So again, like I said, think about your documentation as a picture. All right, so just a little bit about the documentation for the 96365. Very similar to the chemotherapy agents. It needs to be support that it was given via IV, that this was the initial medication for the visit, that the infusion lasted at least 16 minutes. All right. As we move on, again, know what codes can and can't be billed with the 96365. Again, just as with the chemo drugs, there's certain codes that can't be billed together and others that can, but they may require a modifier to be used in the documentation to support that. So we're not going to go back to that code list, but I do want to refer you back to that and make sure you're looking what's in your column 1 and what's in your column 2. And if there are, if there's a modifier that says they can or cannot be done together, and if there's additional instructions, what do those additional instructions say? All right, and now let's talk about IV hydration. So IV hydration is really reported when prepackaged fluids and electrolytes are infused. So these infusions exclude the previously mentioned chemotherapy or therapeutic, prophylactic, and diagnostic infusions. So prepackaged fluids and electrolyte are infusions like normal saline or D5.5 saline, that could also include like potassium. All right. As we move on, a little bit about the coverage of IV hydration. So the 96360 and 361 are intended to report hydration IV infusions. Again, that consists of prepackaged fluids and electrolytes like normal saline D5.5, but are supported with other drugs or substances. So IV infusion for hydration typically requires direct supervision just for the purposes of consent and safety oversight, or other inter-services and supervision with staff. So typically these types of infusions require little special handling to prepare or dispose of. The staff usually do not require any typical advanced training beyond the ability to, administer correctly IVs. And then after initial setup, the infusion typically entails little patient risk and little monitoring. When we think of it in relation to the chemo agents and the other drugs and biologicals that we spoke of. So these codes are not intended to be reported by the physician or other qualified healthcare professional in the facility setting. So IV hydration documentation. The documentation for IV hydration, I'm getting a little tongue-tied, must contain things like the hydration that is being used, and that this hydration was the only infusion service provided on the date of service under review. So the primary reason for the encounter was diagnostic or therapeutic in nature, and that only one initial infusion code was billed, or 2 separate IV sites, or 2 separate encounters. As with any infusion or injection, we require the medication administration record, the start and stop times, the total infusion time, as well as the physician order for the specific hydration administration. along with the rate and the amount, etc. The documentation would need to have monitoring evidence as well. Again, are we looking at the patient's site? Are we checking the rate if there needs to be any changes that are evident for the patient? So things that I think of as a nurse, are we checking the patient's skin turgor? Are we checking the urine output? Are we checking the patient for continued signs of dehydration? So these, again, are all things that your clinical staff should be monitoring to check that patient's hydration status. Are there any lab lab orders being done or lab work being done? Does the patient have any compromised kidney status? Are we monitoring that as well? So again, evidence and monitoring is going to come down to most likely the nursing documentation. And we're going to look at things like ins and outs. We're going to look at patient assessments. We're going to look at any evidence of, skin turgor, or we're going to, look to see if there are any lab values that are improving, etc. All right. Oops. So documentation for the 96360 and 361. So going back to the CPT code, to the definitions for these. The 96360 is IV infusion hydration. That's the initial, 31 minutes to 1 hour. So you would not report the 96360 if performed as concurrent infusion services. And you also do not report IV infusions for hydration of less than 30 minutes. So the add-on code 96361 is each additional hour, and those are listed separately in addition to the code for the primary procedure. The CPT book says you would use the 61 in conjunction with the 96360, and you would report the 361 for hydration infusion intervals of greater than 30 minutes that are done beyond that initial 1 hour increment. You report the 361 to identify hydration if provided as a secondary or subsequent service after a different initial service. So, such as the 96360 for hydration, or it can be reported with the 96365, which is IV for therapy, prophylaxis, or diagnosis up to 1 hour, or the 96374 as IV push for a single initial substance or drug, the 96409, which is the IV push of a chemo agent, or the 96413, which is chemotherapy administration IV technique 1 hour. So again, the 96361 can be used with other codes than the 360, but again, you have to follow those procedure to procedure code requirements and the CPT instructions that tell you, how much of the initial service, how much time must be reported in order to provide that as a secondary. Oops. All right, which takes us to the medical review audit findings. So really when it comes down to the medical review findings on the service, some of the biggest findings that they are seeing is not as much with the initial documentation, but instead with how the codes are reported. Now remember, the two go hand in hand. So if it's not in the documentation, we shouldn't be coding it in, on the bill. So let's talk about some of these examples. Reporting services incorrectly. And we've really spent a lot of time talking about this through some of the different codes that are identified in various services and how you find what codes can be billed with others or can't be billed with others. The majority of the time it comes down to referring to the CPT code manuals and also your procedure-to-procedure files. As we look through the documentation for some of these, and there has to be, you know, time associated, and you can't do the add-on code if you don't meet the time for the initial code, et cetera. And so those are the things that we typically find. And again, if we can't support it, if we can't find it evident in the documentation, we can't pay for it. Knowing what the infusion is for. If you only give your billing and coding staff a code or a list of items administered, it should not be your billing and coding staff's responsibility to decipher how to report these codes. They should be given clear evidence of what the infusion was and any subsequent infusions that were given, so they know how to report those codes correctly together, or maybe they can't be reported together. They're going to need to see the chart to know that chemo was given and followed by hydration of greater than 91 minutes. So, you know, if that were the case. So the documentation needs to be evident for your billers and coders as well, so they can make sure what they're putting on the actual claim, again, matches what is in your chart. That goes along with hours. The chart must contain clear evidence of how long the administration of any service lasted. And that documentation must be supported again on the bill. If we can't see the time in your documentation, then neither can your billers and coders. And none of us can guess how long a service lasted. And we shouldn't try to make a guess. If we were to review a claim and we can't support it, we can't pay you. We can't in good faith assume that something is done. It has to be evident that it was done. So again, remember, it goes back to that old mantra: if it's not documented, it's not done. So that takes us to the last slide, a recap. I know it was a lot of information, and before we move on after a recap, I do want to go through some pre-submitted questions and answer those as well. So in the interest of time, you know, we will try to answer as many questions as possible. And if we have more questions than time, I will put those questions together and answers, and I will send them out to all participants after this event. So I'll send out an email and I'll address all those questions and answers to you in the email. So lots of information today. I hope that your practice learned about some compliance with the infusion services. And we really accomplished this today by going through some of those coverage rules for each of those different types. We talked a lot about documentation and documentation requirements and how to capture some of those things that are frequently missed in your documentation. And finally, we discussed some of those specifics of the recent medical review findings and why maybe in certain cases they can't pay for something that they reviewed as it was billed. So again, before we go into any formal question and answers from the chat, I do want to take some time to go over some questions that we had that were pre-submitted. And this might also help to answer some of the questions that are in the chat. So someone submitted a question about correct coding when the patient presents for infusion multiple times in one day. And this is hard to answer because the answer will really be dependent on whether the patient gets the infusions in one sitting or if they're leaving and coming back. So I'm going to kind of skip over that. But if the person that asked that question wants to send more clarifying information about their question, please put that in the chat. If we have time to get back to it, we will. A good question that came up, can nurses go back and put in the stop time if missing for hydration or medication? So this, if you are the nurse and you forgot to add your start time or stop time or total infusion time to your documentation, this should be made as a late entry. So it should be evident in your documentation that this is a late entry. It should be signed by the person who's making that late entry. It should be dated as a late entry. It will also be dependent on if it was the nurse that was actually overseeing the infusion or a different nurse. So if you're going to make a late entry, it should be made by that person that was actually overseeing it, because then we would have more evidence to support that this nurse actually missed documenting their start time or their stop time or whatever the case may be. So again, the documentation must be evident that that late entry was made by the nurse that was administering the infusion. It must be evident that it is a late entry, and it is allowable and it will be taken into consideration by Medicare. All right, the next one, can an E&M code be billed on the same day as a chemo infusion? And really, this is hard to answer because this is going to depend on if the service is distinct and separately identifiable. So if a significant separately identifiable evaluation management service is performed, the appropriate E&M code should be reported utilizing modifier 25 in addition to the chemotherapy code. Now, for evaluation management services provided on the same day, a different diagnosis is not required for that. Again, the documentation really must support each service separately. You can't double dip information in your documentation. So you can't use the same thing to support the E&M service as you're supporting for the chemo administration service. So they have to be separate and distinct. And then again, a 25 modifier would be used in that case. How do we make sure that the drugs being charged are under the correct CPT code, like chemo, infusion, and hydration? So this one again is, I'm kind of confused about a little bit about the question. I'm not sure if I understand what's being asked here, but it may be that you need to develop some sort of internal process so your billers and coders for your facility know what drugs and what infusions go together. So the documentation really must be evident on what goes with what. We've seen some facilities have infusion order sets that list, here's the treatment, hydration, antibiotics, chemo, and then all the medications to be administered, the rate of those medications, the dosing schedule of those medications, et cetera. If there's flushes after, if there's hydration after. So this is more of an ideal type order set because it's really evident then in the documentation, as well as something that you could provide to your billing and coding department so they make sure that what they're reporting is correct. You would really need to follow the CPT guidelines and the info in the internet-only manuals. So WPS does not have an LCD or an LCA on that. And then one more really quick, and I see we're out of time. And so before I go through this last one, I just want to thank everyone for participating and your questions. They will not go unanswered. We will develop a list of answers, and I will email those out probably next week in the form of an email with all the question and answers that we did not get to, whether they were pre-submitted or whether they came in through the live event. Sorry. Okay, and then there was a lot of questions on modifiers that came in and what are appropriate modifiers, et cetera. And what I'm going to tell you is that there's a handful of modifiers that could be used with Infusion Services. So I do encourage you to go to the Part B section of our website, whether you are J5 or J8, Part B, and just go to the search field and type in modifiers, and you're going to find fact sheets on almost every modifier. The JW is one of those that's most used with drugs and biologicals, because that one's for the discarded drugs. And we have a fact sheet in there for you on that. Again, I want to thank you for taking time to participate in today's webinar. Please, again, remember to take our survey and let us know what additional education we can provide you in 2024. On behalf of myself, all of Provider Outreach and Education, as well as our Medical Review Department, we want to wish you a safe and happy holiday season. And you may now disconnect.